So the fissure in the anal fissure is a longitudinal split in the skin of the anal canal. Acute fissures basically common in children who possess bulky stool. Chronic fissures are most common in the age of 20 and 40 years. Chronic fissures are common in women after childbirth. Anal fissures are more common in men than in women. Multiple fissures may complicate Crohn's disease. Fissure nano. The fissures are the commonest cause of pain in the anal verge. Both acute and chronic fissure are very painful. It begins at defecation and is described the tearing. It persists for minutes to hours after defecation with a thrombing or etching in nature. Bleeding. Acute fissures may streak the stool with the blood and stain the toilet paper. Chronic fissure bleed less and may bleed toilet paper if any. A small skin tear called sentinel tear accidentally may form at the lower end of chronic fissure. This tear may be filled apart. Because of the pain, the patient usually is constipated. The fibrosis around the chronic fissure prevents a good seal around the anus, leading to small amount of mucus leak on the perianal skin. Pruritus could be the presenting symptom of chronic fissure. The symptoms are slow to develop and become a long-standing. There may be a period of remissions. The patient diagnosis of Crohn's disease, trauma, and abuse of children. So the acute fissures, if early and small, may heal spontaneously. Local anesthetic ointment and lubricant laxatives are enough. The leaf application of gelatin cream laxatives, and we have to aim of the treatment and to lax and sphincters, healing of the epithelium. Chemical sphincterotomy using injection of Botox into the internal sphincter. Advantages of the chemical method gives a more sustained effect than gelatin cream. Now, the fistula is a tract lined with epithelium or granulation tissue, which connects two epithelial surfaces, may be connected to body cavities or one cavity in both the external surfaces. The fistula connects lumen of the rectum of an canal with the external surface and by the granulation tissue. So the internal opening is below the anorectal. It could be the following: the transsphincter intersphincter vessel. It could be the lower level transsphincteric, intersphincteric, or subcutaneous or submucous. High level fistula opening above the anorectal. It could be the following: the extrasphincteric, transsphincteric, intersphincteric. So Park's classification is that intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. Patria purulent discharge from the external opening. Pain is episodic of the fistula. First, the pus. The pus doesn't discharge. Pain more intense and thrombing. The discharge causes the pruritus ani. There may be a minor bleeding from the external opening. The symptoms in general are episodic, but the condition hardly ever cures itself. So there is a Good-Fals rule. Good-Fals rule shows that the internal opening of an anterior fistula lies along the radial line drawn from the external opening to the anus, where the internal opening of the posterior fistula lies in the midline posterior. You can see here in diagram, there is a radial position. If we'll be talking about the midline, there is an internal external opening over here. It goes the radial to the inner of the mucosa of the canal. And if you are talking about the posterior is the anterior position. If there is a posterior position of the midline, shows curviness comes. The external opening is visible anywhere around the anus, usually close to the anal margin, but sometimes a few centimeters away. The opening is not a tender, but the thickened tissue around it may be. Fetus or purulent discharge may be visible. The rectal exhibition is not painful. The internal opening may be felt two-thirds or positive, posterior one-third or anterior. Sigmoidoscopy and proctoscopy are essential to exclude underlying disease like Crohn's or carcinoma TB. The inguinal lymph nodes are not large except if there is inflammation or secondary infiltration by carcinoma. Don't forget general examination if there is a suspected systematic underlying cause. If the fistula occurs, visulogram, endoanal ultrasound, MRI, these are the investigation you can go for the fistula. Pyrrhonidal sinus hemorrhoids and suppurative incontinence, Crohn's, Thomas, these are all the deficient diagnosis for the fistula. The treatment is superficial and low anal fistulas are laid open. When there is a superficial and low level fistula, you can go to and open the fistula. Healed by granulation tissue. There is no loss of continuity. This is only done if the fistula lies below the rectal vein. High fistula suprasphincteric, only the lower part of the fistula is laid open and the non-observable ligature Time the cytol is passed through the column fistula. 2 to 3 weeks. The sphincter is fixed by scar tissue. Subsequent division of the upper part of the tract either by a second operation or tightening of the leg open. Lying open, a whole tract will completely divide them. So, inflammatory bowel disease, symptoms, pain, ulcerative colitis, and Crohn's disease, lower abdominal cramps, leaves the bowel movements, Crohn's disease, constant pain, often the right lower quadrant, bowel movements. Stool blood, grossly blood stool, and ulcerative colitis. Inflammatory bowel disease, abdominal mass, ulcerative colitis, abdominal mass, Crohn's disease, mass, often in the right lower quadrant, gastroenterology tract affected by the ulcerative colitis, Crohn's disease, bowel tissue affected, mucosal disease, no granuloma, Crohn's disease, transfer disease. So these are differential types. Ulcerative colitis shows only affects only colon and continues from the rectum. Crohn's disease, mouth to anus, partially affected discontinuous regions. These are basically the ulcerative colitis, no abdominal mass, but Crohn's disease shows the mass in the right lower quadrant. So these are the differential diagnosis. So the inflammatory bowel disease shows abdominal mass in ulcerative colitis and Crohn's disease. Sorry, no mass in ulcerative colitis. Gastrointestinal affected. Ulcerative colitis shows only colon and continues from the rectum. Crohn's disease can occur in the mouth almost discontinuous skip regions. Lab investigation shows the CBC count, serum electrolytes, blood urea, nitrogen, creatinine level, blood grouping across matching population, profile PTT. Focal bleeding test. Normal lose 2.5 to 1.5 ml per day from GIT. 3 types of tests. White based hematocult sensor. Good for detecting large, more distal lesions. Inconsistent. Need greater than 10 ml daily loss for positive test for 50% of time. Can detect as little as 1 ml of blood in a stool affected by dietary factors. Foods which darken the stool make it harder to read. Fast positive from dietary iron. This is basically hemoccult investigations. Immunochemical do not detect bleeding from upper GI tract, localized to colon. Can detect as little as 0.3 ml of blood in stool. Levels required. Heme post-foreign test. Very sensitive, high false positive investigation. Fecal bleeding test is 60-80%, and the test is positive patient requires a colonoscopy. Or double control bleeding minimum and sigmoidoscopy. Test is positive and the colon has been cleared unless identification is present for further. Investigation is a bare minimum. No role diagnosis of rectal or GI bleeding. If you use all obscure any subsequent attempts to visualize the electrography or colonoscopy. Double contrast enema is 70% detective hormone bleeding is one. Diagnostic and therapeutic capabilities can be used even with ongoing massive bleeding characteristic endoscopic finding of recent upper GI. So colonoscopy show you the all over the colon anatomy and active bleeding vessels. It is a 6-24 hours post presentation. Patient must be stable condition, low bowel preparation, and it is a time when recurrent bleeding is desired. Increased risk of small, it could be caused to bowel perforation should not be attempted with ischemia of severe mucosal inflammation. So endoscopy may you not go for this endoscopy. Endoscopy coagulation. Choose of bleeding area 2% of 2%. Diverticular bleeding. Will you not be able to endoscopically coagulate? Colonoscopy, virtual colonoscopy may have a role in assessment of patient. You can see the bleeding diverticulum. Detects bleeding is an anti-platinum sulfur chloride test able to detect the low rates of bleeding. Preferred method good for intermittent bleeds and able to visualize reverse pain. Angiography is visit angiography femoral punctured over specimen in MA. Because positive test of extraction can detect hemorrhage rates 0.5 ml per minute. And an infusion embolization. Normal selective angiogram. CT angiogram, new and overwhelming technology requires a modern CT scanner, fast, 50 less than 50 per minute. Non-invasive, identifies large and small bowel hemorrhage, sensitivity specified 70%. Investigation of obscure geography, 5% of patient bleeding which remains unknown despite extensive diagnosis. Push enteroscopy, capsule enteroscopy, small bowel flow through Nickel scan, these investigations, you can go for GI bleeding. If there is obscure GI bleeding, you can go for the Nickel scan, the Technion 99 scan, diagnostic laparoscopy, and as for laparoscopy, capsule endoscopy. These investigations you can do. Push enteroscopy, the 2x7 Roentgen scope, scope, with the balloon tape, this glasses board. Nickel diabetes of women of mental interest type disease of two stony pick up nickel secretary against nickel 50%, 85% sensitive, useful for. So it is a logarithm of vessel load bleeding. When you there the acute lower GI bleeding, you go for the aggressive volume resuscitation. Then you go for the digital rectal examination and exam and endoscopy. You have to pass NG2. If NG2 positive is a bleed, you go for endoscopy and the treatment. If NG2 is negative, then you can go for DRE to see any endorectal bleeding. If there is endorectal bleeding, you treat it. But if there is a digital rectal, if there is a positive blood, there is no any treatment. You can go. Then you have to assess the bleeding. Either it's intermittent bleeding, moderate, or massive bleeding. With moderate bleeding, then you can go for the RBC scintigraphy. With massive bleeding, you can go for mesotic angiography, and you go for intermittent bleeding, you can go for the colonoscopy. So the RBC matrix is positive, you can go for the mesotic angiography. With the positive segmental resection. If there is a ischemia, there is any obscure, there is anything which is obscure, the mesotic vessel, you can go for the segmental resection. Positive, then you can go for the. So if there is a negative, you can go for the intraoperative endoscopy. Then subtotal. If there is a positive, you can go for the segmental resection. If there is a negative, you can go for subtotal collector. So in intermittent bleeding, you go for the colonoscopy. If the negative, you have to observe the patient, and then you go for the intraoperative endoscopy. If there is a rebleeding, then you go to RBC scintigraphy and to see any confirmation. If there is a colonoscopy is positive, then you go for the endoscopic treatment. If there is a rebleeding